The examiner should begin at the foot of the bed. The legs are inspected medially, looking for an effusion. The examiner then lifts the heels, dropping the patient into forced full flexion. The knee should then be taken into full passive flexion. The presence of pain or blocked flexion may be a sign of meniscal pathology. With the knee at approximately 90 degrees of flexion, the medial joint line can then be readily palpated. The examiner walks his hands up the medial joint line and can then palpate along the medial meniscus. Damage to the medial meniscus, including tears or degenerative changes, will often be painful on palpation. To assess the collateral ligaments, the knee is placed in extension, with the fingers placed on the joint line. The patient's leg is cradled between the elbow and hip. Valgus and varus loading can be applied to assess the integrity of the medial and lateral collateral ligaments respectively. The amount of joint excursion and end feel are both quantified. Next, the anterior cruciate ligament can be assessed. The knee is placed in 30 degrees of flexion. While using one hand to immobilize the femur, the examiner applies a forceful anterior tibial thrust. A firm end feel appreciable by both the clinician and patient indicates normal ligament integrity. The patellar examination may begin by deviating the kneecap both medially and laterally. The medial and lateral patellar facets can be palpated as well as the superior and inferior patellar poles. The tibial apophysis may also be palpated for tenderness in individuals with suspected tibial apophysitis. To examine for the presence of an effusion, the concavity medial to the patella is inspected. The joint is then stroked medially from caudad to cephalad to milk any fluid away from the examiner's hand. This is followed by a superior to inferior stroking on the lateral aspect of the knee to milk the fluid back to its origin. Note that a joint effusion can be seen in this patient with this maneuver.